Can I welcome everyone today to the Health and Wellbeing Board? Can I remind everyone that is present that we are being webcast and your images will be translated around the world, as we found out when we looked at where people are watching us from. Membership of the board, have any apologies?
Councillor Catherine, Steve Walker, Catherine William, Richard Spencer Hensel and Jackie Getman.
Thank you. Minutes of the previous meeting, are they agreed? No corrections? Sorry, yes, Steve?
I'm not being funny, but it could say somewhere that I chaired.
Does it not? Does it not say that? Can we correct that? Yeah. His moment of fame. Can I move on to the declarations of interest? Any members any interest to declare? None. Admission to the public. There are no items in private session on this agenda. Deputations and petitions. Have we any deputations and petitions? No, but we do have public questions. Can you press your button?
I'm Christine Hyde. I'm from North Kirklees NHS Support Group. Forgive me if these questions are going to be addressed in the speech or presentation, but anyway, I'll ask them. Is there an integrated commissioning board for the local Kirklees plan and another for the regional West Yorkshire Health and Care Partnership, or are they both the same one? And which bodies are represented on them, or it? So that's the first one.
If I start the answer, but does Christine need to press your button? So there's a paper on the agenda about the establishing the Kirklees Integrated Commissioning Board, which is just about commissioning health and social care services for the people of Kirklees. The governance arrangements for the West Yorkshire Health and Care Partnership are separate, and there's a range of elements to that, including there's a CCG governing bodies. What's the correct term? I forget. There's a joint committee of the CCGs and a range of other bits of the parts of their governance structure, which run to about 7 or 8 different components. My understanding is that most of those are now on the Health and Care Partnership website, but they are actually separate but linked to the Integrated Commissioning Board that we're establishing in Kirklees.
Another question?
How will conversations rather than referrals work to get people health treatment in the future? Well, it was something Steve said in the scrutiny committee, and he said in the future we'll be having conversations rather than referrals for health. This Steve? No, Steve Brennan, sorry.
Hi, yeah, when we were talking about that, that was in relation to having the community-based, place-based ways of integrating health and social care. And the idea there wasn't that we're going to do away with referrals as a way of making the system work, but what it was about was reducing the number of handoffs between services and between clinicians and other people involved in people's care. So the idea being that when people come together and work in those natural communities, they work as more of an integrated team, and there is much more co-location of the people in that team, and therefore they're better able to come together and have conversations with each other and with patients about how we coordinate and deliver their care, as opposed to those teams being more disparate and there being more of a sort of a paper-based referral mechanism between different elements. So that was what that was about.
I can tie this to your last question as well. I mean, whatever we do with West Yorkshire or Kirklees or even in our neighbourhoods, we've always said that we're going to make decisions as close to patients or the population as we possibly can and not change things that we don't have to. So it will all, you know, if we can keep it local, we will be doing it local.
On to item 7 now. Steve Brennan.
Okay, thank you. I won't talk through the paper in a great deal of detail because hopefully it's fairly self-explanatory. Just a really brief summary of what we tried to do in this. So hopefully it tells the story that we've been telling for a few months now, and it makes sense to people because they kind of recognise where we're getting on these things. What we're talking about here is predominantly the new Integrated Commissioning Board, which is going to start in April. Terms of reference for that Integrated Commissioning Board are included in the paper. They've been taken predominantly from the existing terms of reference of ICE and the Better Care Fund Partnership Board. Included in there and in the paper are some things around the initial areas of focus that we want to work on. We've put a fairly short time span on the terms of reference because we recognise this is an evolving process, and it may be we need to take stock in about 6 months and just see whether they need tweaking or not. There's also a little bit in the paper about some of the other work that we're on with in terms of helping that board do what it needs to do by changing some of the other arrangements we've got. And it mentions identifying some project teams and lead officers to take forward the key pieces of work, and just makes a brief reference to what is actually quite a lot of work in terms of reviewing the work of the various groups that sit underneath ICE and the Better Care Fund, and also thinking about how we align the staffing resources between the Council and the CCG, so those teams of people begin to come together to deliver the work of the Integrated Commissioning Board. I won't talk in any more detail, but I'm more than happy to take questions on what's in the paper.
Thanks, Steve. I have 2 questions. Well, on under 4 of the 4 scope and objectives under 4.7, you got me there. You've got the supporting organisational development by establishing a single culture where our staff adopt one set of values and behaviours. I mean, I could understand why that's written there, but that's a massive job and going to take an awful lot of time, wouldn't you say?
Yes, I would. Again, that is one of those ones where it's a continuation of things we've been doing for a number of years. So we have got a long history of working together across health and social care in Kirklees, and this is about continuing to do that. Different bits of organisations have different cultures, so it's not necessarily going to be all permeating, but certainly when we come together to think about how we deliver health and social care, that's where we're really talking about needing to focus that going forward.
So my second bit, just a bit further down then on 4.8, could you give me some examples of bullet point 4 where you said receiving financial performance and quality information on existing services? What sort of things do you see coming in there? Because clearly the Council has its statutory duty to monitor its services and the CCG the same. But obviously, so give me some examples of what we might be doing together.
Yeah, no, that's not a problem. In terms of the finance side of it, what we're talking about doing there initially is 2 things really. One of them is around continuing care and beginning to understand better together what both the Council spend and the CCG spend on adult continuing health care, learning disabilities and mental health. So it's really about, it's not replacing what the organisations do themselves, but what it's about doing is getting a better collective understanding of what we're spending and how we spend it that might then lead on to something else, which might be a slightly different way of spending that money. The other thing we've said we will do is, as we begin to build examples of where we're bringing services together over and above what we've already done and developing those place-based, community-based systems of delivery, will attempt to bring together the money that's represented by those services to give people a sense of whether we're bringing together, for sake of argument, £20,000 worth of services, 200,000, 2 million or 20 million. So it's really to help inform the ongoing work around how we deliver services. So it won't be replacing the things that we see through the CCGs, it won't be replacing what the local authority do, but it's to help inform decisions about how we can better commission and deliver services together.
So it mentions within the scope and objectives about delivering the strategic needs assessment for Kirklees. And then on the diagram it mentions about it being reported into the Health and Wellbeing Board as well. So if, for example, some of those objectives weren't being met or there were issues where they could be improved, would we be able to get that information to the Health and Wellbeing Board to provide that appropriate challenge if we're not on the committee?
Yes, I think what we were trying to get at there is that in terms of delivering that, there'll be a whole range of activities that need to take place, some of which will fall into the sphere of integrated commissioning, and that's what we'll try and do through the integrated commissioning board. Absolutely, the intention is to report back up from the integrated commissioning board into the Health and Wellbeing Board. So it's not that it's taking over what the Health and Wellbeing Board would do, but it's a supportive mechanism. But absolutely there would be a reporting mechanism back up to make sure we're doing our bit of it, because like I said, they're quite far-reaching and not all of them would necessarily fall into the scope of this.
I guess my question is a point of ignorance, really, in terms of in attendance from the council. Is a health policy officer. What's a health policy officer and what do they do? Oh, is that you? Oh, right, okay. I didn't know that was your title. Oh, is it? Okay. So what do you do?
Can I just ask a clarification question? Is it just adult social care that's part of this integrated commissioning board? Because you've got people from the adult social care on your board, and then you've got somebody from children's that's in attendance. And so I'm just wondering, is it just for adults? And in your document, you've got that where it will feed into in the CCGs, which particular committee it will feed into in the CCGs, but it just says in the council's governance structure for the council. So can you just clarify?
One of the things that's I think important about this is we're not seeing this as like a finished product, and certainly the discussions we've had so far are about the bits of the children's experience of health and social care which are integrated between the council and the CCGs will be the main focus. So the people who are involved have clearly got the relevant delegated authority around those issues. In the CCG, I think one of the things we'll need to do from a council point of view as children's services the improvement journey continues is continue to be clear about which issues need to go into the improvement board and which issues need to come into the integrated commissioning board.
Is that clear? I'm hoping that someone understands it. Yeah, I don't either. I don't either. It's an
So if I try and
after watching Father Ted the other night, it's an ecumenical question. Richard.
I was going to use examples.
I just wondered whether it was worth reflecting that this board is bringing together a number of existing arrangements. It's not creating at this point a new set of arrangements. So a rule of thumb would be if arrangements for children are currently in a joint arrangement, they will continue to be dealt with through this. If they're not yet in a joint arrangement at this stage, they won't be dealt with through this. But as we become clearer about services where we should commission them once across the two CCGs and the council, they may fall into the scope of the board. So it is about that bit about it is as is, a number of existing groups being brought together rather than creating something which has got a much wider remit.
Anything further, anyone? No, thank you. Can I move on to, I think because we had a plethora of Steves at this meeting, we've decided that Viv's going to be Steve Walker for today. So she's going to give her a report on Children's Service Improvement Journey.
Thank you, Chair. Today I am Steve. I've had the portfolio for Children's Service, I think this is week 6. Having said that, I've been to a couple of improvement boards and corporate parenting boards and so on. At the risk of repeating information that this board has, the Department of Education approved a Children's Services Improvement Partnership between Kirklees and Leeds City Council. Eleanor Brazil is the Commissioner appointed to help us along an improvement journey. And today, I think, he's coming out a Children's Services Improvement Board update, which I think will go to members of the board and their organisations. But I think I will check whether that can go out to a wider audience. The Improvement Board, the people attending that, and it is well attended by a range of organisations, are working together to deliver the 10-point improvement plan. And I'll give you some successes in terms of there's a reduction of agency staff exceeding the improvement plan target, which was 25% by March this year, and it has exceeded that. There's been a reduction in staff turnover. The staff turnover in May 2017 was 25%. By the year end of December, it was 13.7%, which may seem high, but that's better than the national average in social work terms. There's been a reduction in staff sickness between March 2017 and January 2018, a reduction of 14%, which is always to be welcomed. We're getting more and more applications for posts that we have vacant, and the applications are better quality, if you like, people with much more skills and experience. And I think that demonstrates people want much more to come and work within children's services in Kirklees. We've got a comprehensive professional development framework, which is agreed and in place. And there's improved staff support, some fairly mundane things like IT and officers, but they are just as important to have staff feeling cared for, looked after, and I welcome those. There's still a lot to do. In some areas of children's services, we still need to work hard at reducing caseloads. We still need to improve staff retention, and we need to embed the new arrangements for supervision. They are in place, but they need to be embedded across the whole organisation. As far as the corporate parenting board goes, which I've chaired it twice, it's very clear to me that more data needs to come to that board, and there needs to be more clear challenge from that board, and the voice of the child and young person needs to be heard more clearly at that board, and it needs an updated strategy, apparently from April 2018, which was a big surprise to me. We've appointed experienced leaders. We have a new service director in terms of Elaine McShane and 4 new heads of service, so that leadership is strengthened and in place, which I welcome very much. Last week we had an Ofsted monitoring visit, and I had the deep joy of being interviewed by an Ofsted inspector for the first time in my life. It was interesting, is all I can say. And they were talking and questioning me about the corporate parenting board, and I was very clear as to what I felt I had in sight and what needed to be done. And at the feedback meeting, they fed exactly back what I'd said to them, and they did agree with me. We should have had, and I don't know if we had, a draft letter yesterday, I understood, about their response to that monitoring visit. I felt I feel reassured by some of the improvements that have been made in children's services, and I was just getting the feel that they were spotting those improvements too. So we'll wait and see. We should get the draft letter very shortly. I think we have to reply within something like 5 days, and then it will be published. But unless there are any questions, that's as much at the moment as I was intending to report.
Thank you, Steve. Have anyone got any? Sorry, go on.
Please don't slap me, Viv. It was just a question about the voice of children and young people. So you've mentioned about how you're trying to strengthen it within your governance processes. Yeah. I remember within the original report there was some challenge about the voice of young children and young people being heard operationally within the work that the social workers are doing. Do we have any data or evidence to show whether that's improving or not?
In terms of the data on particular cases, do you mean as such, or?
Yes, within cases, but also overall, do they feel much more comfortable and happy about the decisions that are being made on their behalf?
I'm absolutely sure that there will be individuals who feel perhaps that their voice isn't being heard or are unhappy about the turnover of social workers and so on. One of the things that every authority has is a looked after children care council and a care leavers forum, and I think in Kirklees that's been slightly not neglected, but it's gone to seed a little bit. We have, and I don't know if colleagues are aware, we have a place called Number 11, which is in the building that was the old registry office in Kirklees, in Huddersfield. And Number 11 is a drop-in centre for looked after young people and care leavers, people who've left care, where they want to come and use the facilities there, seek advice, support, or just come for a chat. And I've been quite a lot of times. Within that organisation, we have, in that service, we have 4 apprentices who are care leavers from Kirklees, and they are working and going out to the children's homes and foster care places, talking to young people and children, and re-establishing and reinvigorating the Children in Care Council and the Care Leavers Forum. I'm very optimistic about that. It's worthwhile, if people haven't been, to go to Number 11 and go and see the folks there. I've sat there quite a lot and talked to a lot of the young people who use Number 11, and I think it is a brilliant idea, which I have to say colleagues from Leeds are wanting to replicate in Leeds because they haven't got something like that. So we are improving it, but how the Corporate Parenting Board hears those views is something that I'm working on and I want to build into the strategy.
Anyone else? Can I thank you for that, Viv? Can we move on to the Phil Longworth, who you see from your minutes, is the Health Policy Officer. Steve Longworth. Phil Longworth. Yeah, Steve today, yeah. Sorry, Phil, but I'm just a bit wary about the title of this. Are we assuming from this that winter is over? No. Good.
So this is about just seeking the board's support for an approach to trying to reflect on winter when it's over, and to make sure that as a Kirklees system we're learning the lessons from what's been a very has been and still is quite a pressurised time for the health and social care system. So the operational leadership for making sure we respond positively to the pressures over winter comes from 2 bodies. There's a A&E Delivery Board for Calderdale and Huddersfield, and an A&E Delivery Board for North Kirklees and Wakefield. So they're actually based on the acute hospital footprints. So both those bodies, like I say, they're responsible for the operational work over the winter and learning from their experiences. Obviously, that means that some of the things they look at aren't particularly pertinent to us, because what's happening in Wakefield. So this is about us as a Kirklees system trying to learn from what has gone on in the two A&E delivery boards and to have a Kirklees-wide perspective on how we can actually make sure that we respond to the challenges over winter in a more proactive, effective and efficient way. So the proposal is to make sure we don't duplicate what's done by the A&E delivering boards, but draw on that. They do an awful lot of work in terms of analysing the data that we collect over winter about different activities. I think it's fair to say that an awful lot of that data is quite hospital-focused. So the suggestion is, in terms of taking a system-wide view for Kirklees, we broaden that out a little bit. Similarly, the A&E delivery boards have got very detailed logs of what was done. And again, it's not a question of replicating that, it's a question of saying, okay, those things did happen, but reflecting more on what impact they had, because sometimes when people are focused on the very operational delivery, it's difficult to stand back and take that slightly longer term, wider view of what difference those things have made. I think anybody who's been involved in responding to the winter challenges know that it can be a very challenging and difficult time for all those people involved, both patients, frontline staff and managers and commissioners. And so it seems sensible, because from the evidence we've got from elsewhere, that how people actually respond from a sort of system leadership point of view and a relationship point of view is crucial to making sure we can do the best for patients, users and carers. So we wanted to have an opportunity to reflect on how it felt for people, not just what happened. And the final thing, which I've alluded to already, is just to say there's, over the winter, quite often the most useful things come out whilst you're in the midst of things. Two really useful things came out over the winter. CQC is doing some system reviews across the country with some of the most challenged systems. So there's learning from there. There's learning from some work that was commissioned by the Better Care Fund support programme that lots of people, I think, have looked at and said, yes, that's incredibly helpful stuff. So we need to use that as a bit of a test for ourselves to say to what extent are we picking up on the lessons that have been learnt from elsewhere. So the proposal basically is to try and use those different sources of information, speak to people who are directly involved in trying to manage things over winter, bring people together as a Kirklees system to reflect on that and identify a few things from a Kirklees point of view that will add to and hopefully work alongside what the A&E delivery boards are doing, to say these are critical things we need to learn from our winter experiences and identify a limited number of actions that we can all commit to try and make sure that the way we manage winter in future is working better. And so the expectation would be we get that done when winter's finished and bring it back, hopefully, to the next Health and Wellbeing Board meeting, which is towards the end of June.
Do you want to add anything, Carol? Steve?
I think it's a question, and it could be a question I'm asking myself. I wonder what's a good winter look like? And that, you could ask that to health, you could ask it to social care, you could ask it to patients, you could ask it to the ambulance service. Because, you know, if we're going to do this piece of work, which I agree is important to do, and I will input into it, you know, I just wonder what good looks like, you know, because winter is going to happen again. It's going to be awful in January next year. And we need to have done some learning, but what would good look like? I don't know if you want to start, Phil.
It's not an answer to it, but it is linked, because I was looking at the points under 3.3, which talks about the format we're going to use for the review. I think there's actually a sort of point E, which is what will we do differently next year, so that when we get to the end of it, and we've identified those areas, you know, we need to be really, really clear about what we're going to do differently next year, much earlier than Christmas time or the first week in January. So I don't know if it's implicit in there, Phil, but maybe we just need to draw that out a little bit. But I'm not sure I can tell you what good looks like, I'm afraid.
Okay, just to say that CHFT are keen to be round the table and be part of setting the terms for it, as well as providing information for it. that's a really interesting question that we can ask, isn't it? What does good look like? What do we all agree that we're aiming for next year?
Yeah, I mean, I welcome this piece of work, and I think it's absolutely right. I think one of the problems we've got is the data often is mainly secondary care based rather than necessarily community focused. And I guess I'm thinking about, if we are going to do this, what's the gaps in the data would be a key question for me, so that actually we can then look at next winter to see what's happening and making sure we're measuring the right things in primary care in the community. I mean, I'm thinking, for instance, in primary care, there's no data really captured about numbers of appointments and pressure on demand in primary care, other than maybe some phone calls to practice managers to say, how is it feeling, or whatever. Interestingly, there was something that came from the BMA recently about, you know, a system to capture that in primary care, which I think we ought to look at. And actually almost developing an Opal system for primary care for next winter that actually flags up to the system where there are pressures in primary care. Because I'm fed up as a GP getting Opal 3 messages from acute providers, but actually they don't really necessarily realise what my Opal situation might be in my own practice.
I'm really supportive of the themes within the document, but I just wanted to clarify something, and I may be being a bit slow because it's been a long day, but are you going to be interviewing any patients or carers to understand their experiences of the pathways in winter?
When we were thinking about who the different people are we need to involve in this, absolutely we need to think about how to involve patients. We need to have a conversation with Rory about how best we can use what Health Watch has already picked up. There are some of those messages coming through the A&E Delivery Board, but I think similar to the point that David's just made about we haven't got particularly robust measures of the pressure in the social care part of the system, the primary care part of the system. Similarly, I'm not sure that we've got patient feedback particularly well wired into the winter system either, because most of the data does tend to be about, it's hard data and it's about pressure on the acute part of the system.
Just add one more. I think it's absolutely right doing this from a Kirklees footprint perspective, because I think it will give us a different view than the view we get through A&E delivery boards. But I think one thing we might just want to clock is that we will need to also gain a perspective from services that operate on a more regional basis. I'm thinking particularly of the ambulance service, 111 and our out-of-hour services, which we might, are not just Kirklees commissioned.
Just in response to that point about patient views, we're very happy to help out with experience-based design sessions, something like that, getting groups of patients who've been through the system over winter together to find out what their experiences were, what they felt, and any learning that we can take from that. Happy to help with that.
If we move the recommendations, I think it would be logical to add a further one, given what I think whether it was Steve or Dave said it, about what are we learning. I think we should say what does that say, ask us for next year. So I think we should be clear, because if we're going to collect it and going to do it, we've got to have a purpose for doing it. And obviously the main purpose is to learn for future years. And as you said, it's difficult to know what next year will be like, but some things do keep repeating themselves.
Yeah, I think it's quite important to learn from each other's perspective as well, to see each other from each other's lens. In the hospital, we have a very clear view about how it felt for us, but we're not GPs, so we don't know how it felt for GPs or social care. And that's not about being right or wrong, that's just having a multiple lens on it.
I just know that every day when it's frosty, it costs us £9,000 to grit the roads. So that we'll less frosty winters. Yeah. Can we, with that provision, that we do have that provision, a sentence of something about that the whole purpose of this is to learn for future years. Can we accept the recommendations on this paper? This is one we do have. All agreed? Yeah. Thank you very much. Can we move on to item 10, Nicola? Press the big one.
Try
I brought a paper to the Health and Wellbeing Board regarding the pharmaceutical needs assessment. The board has received previous updates on progress with this. As the board's aware, it's a statutory duty for the Health and Wellbeing Board to publish its P&A on the 1st of April 2018. This paper is to present the board with a completed document which has all the amendments up to date, completed and ready for publication. Request is for the board to receive the amendments and the executive summary, invited to ask questions and to approve the P&A for publication.
Anyone any questions?
Is it intentional that we've only got one member of the public listed as a respondent? Because unless I'm reading it wrong, there's only one member of the public on this list.
Sorry, was the question about the public consultation and the numbers of responses received from members of the public? Yeah, we did have a communications plan, and we did involve Health Watch throughout the process and kept Health Watch informed. And then we just brought all of the consultation responses in when it closed, and what you see there is what basically came back as part of that consultation process. We did our best to reach out to the public, but I do the P&A free riding as well, and I have found from both authorities it's a very difficult document for the public to actually take on board with the nature of it and everything. But we do get some responses, but we don't really get a lot from the public, even though we do consult with them.
Just to clarify, how often do we receive this report as a Health and Wellbeing Board? Because the reason I asked that question, I seem to recall every 2 or 3 months we get one. Is it once a quarter or is it once a year? How often should we be receiving this report? Because, I mean, it's really useful information and it's really great and, you know, gives us very rich data, but I'm just wondering how often it needs to come to the Health and Wellbeing Board.
Okay. The only time that you will receive anything is when there's a big change. For instance, we've got 2 pharmacies about to close, and then what would happen in that instance is we would consult with the P&A group and make a decision as to what effect those pharmacy closures are going to have on our pharmacy provision in our area. And then we would need to publish supplementary statements, which I would need to publish and present to you as some form of briefing document, because obviously you've got to sort of be aware of those. Other than that, the document's published on a 3-yearly cycle, so unless there's any major changes with pharmacies coming, going, closing, or anything that you have to be aware of as a board from a legal point of view, the P&A is a standalone document, so it's published and then it doesn't change. So if anything changes to the document or the body of the document, we have to publish the supplementary statements alongside it to keep, NHS England, aware.
So I think what you're going to decide then is it that your time is flying past quickly for you, or that we've had more changes just recently?
We must have had more changes. I don't know if it's just me, but I remember reading these sorts of documents on a regular basis at the Health and Wellbeing. But and I absolutely understand why somebody needs to have an oversight of that. But I presume that is the group that's working beneath this, rather than necessarily the Health and Wellbeing. But for instance, we don't receive things about when, I don't know, dental practice changes or optical services changes or GP services change. What's special about pharmacies that means it has to come here on a regular basis?
Is there a strategy? It's asking us to approve. It's asking us to approve that we publish this document. So it's implying that we're endorsing this document, which has come from someone else, because it's asking us on the recommendations. We're asked to approve this document. for publication, so by us publicising it.
I know what it's asking us, but my question was about how often do we need to receive it to be asked the question and whether it's appropriate and why don't we get other stuff.
Yeah, that's why I'm endorsing your question. Why are we approving something if we don't know what it's got to come here for?
And I suppose I'm not asking a similar sort of question, but I'm picking up on David's theme. In section 2, there is a reasonable and adequate choice of pharmacies in all areas of Kirklees. We haven't had a single person in 3-4 years complain about the numbers of pharmacies in Kirklees. We get people every single week talking, as David just suggested, about access to NHS dentistry. There are 59 dental practices in Kirklees at the moment, and on March the 1st, none of them was taking on NHS patients. So, as a board and as a group of system leaders, there's a question for us about the amount of effort we're putting into checking a perfectly acceptable spread of pharmacies when actually another part of our system is completely failing.
So I think the answer to why the P&A comes here is because it has to come here. It's a statutory, one of the few statutory duties of the Health and Wellbeing Board, whether we like it or not. That's entirely different to other things such as the availability of NHS dentistry or access to primary care GP services, which isn't a statutory duty, but this board might equally be interested in. So we're stuck with the P&A unless primary legislation changes, plus updates potentially. But I think, Rory, you're making a proposition that it would be helpful if the Health and Wellbeing Board received some further information, potentially had a look at NHS dentistry, given that, from a public perspective, is a more pressing issue than pharmacy.
Presumably there must be some group that does a dental needs assessment or an ophthalmology. No? Okay, so what's special about pharmacies then when we've got a good service?
Because it's a statutory duty that we have to. I think we asked that question about many statutory duties we have, David. Okay. But I mean, I think that. Yeah, but yes, and obviously we need to know. I think you're right. I mean, some of the other questions that you've asked are probably more important. Why are we not reviewing other provisions as well as this one? I think that's probably. Yeah.
It was the Health and Social Care Act that made it the responsibility of the Health and Wellbeing Boards. And the Director of Public Health has delegated she has responsibility delegated by yourselves, and I'm the lead officer for it. And I'm doing my best to try and maintain it for you.
Perhaps any changes could come to us by exception when they only need to, please? Because actually, you know, it is, but I do, and I'm sure I'm not on my own in saying that I have had lots of these reports in the last 3 years. I can think at least 7 or 8 times.
It's difficult if we've got a statutory duty to approve the publication of these, and it has to be because every change. So it's going to have to. So when we're going to have to be. How long we discuss them, David, is our choice. How long we discuss them is our choice. But they're going to have to come. They're going to have to come for us to say that we approve the publication. Yes, sorry.
What are we going to do about Rory's point about dentistry? Is there something as a Health and Wellbeing Board we could do to support that? Because I think that's really important.
I think we should be reviewing what other, as David pointed out, the dentistry and other provisions. I think we should be mindful of some way of doing an overview of all provisions, and I think we should be trying to look for a list of that. So can we have someone giving some thought to that, please, for a future board?
In the absence of the DPH, I'm going to suggest that would sound like a really interesting thing for her to sponsor. So she'll never let me come to this meeting again. I think Rory and I perhaps will have a conversation outside of this room. We have been having some conversations with NHS England. The commissioning and contracting for dentistry is really, really complicated, and I'm not going to pretend to understand it. We also have some work that's being done for us at the moment by a dental specialist registrar. Who knew that you could be a public health dental registrar? And he is working with us to do some overview of oral health, but increasingly I'm of the view that actually we're all right with our oral health, we know what we're doing, our real challenge is about access to dentists. So if I commit myself and Rachel to have a conversation with Rory outside of this meeting, but I wish we could do for dentistry what we have the capacity to do for pharmacy. It would be brilliant.
I think that makes sense. But we still have to approve that we publish this paper, otherwise it won't get published. Do we all agree that we publish this paper? No. Thank you. Thank you very much. Can I move on? I mean, is there anything difficult in item 11, or is it straightforward just tidying up because of the changes? Is it contentious at all, or we all agree? Are they all agreeing?
No, there isn't anything contentious from my point of view.
Can we all agree to the terms of reference? Sorry, yes, Carol.
Just in case I've missed something, because it makes reference to the change in management arrangements across the two CCGs and the fact that one lay member represents both, which led me to believe that there might be a proposed change on the back of this. But when I've read the terms of reference and the voting, it remains unchanged. Is my understanding correct? Yes. Yeah, I just wanted to check, because it was just a bit...
Can I just, certainly our understanding from reading the advice we've had from legal is that those of you, yourself, Carol, and Fatima, who are representing two CCGs could vote twice. Yeah.
Okay, all agreed to these terms of reference? Thank you very much for everyone for attending.